Okay, hello everybody. Brian Dahl from Bone and Joint Center in Bismarck. Going to talk to you about partial knee arthroplasty. Kind of a brief overview here. I have no disclosures for this talk. The outline of this is going to be compartmental arthroplasty. What is it? What it's made of? Who needs it and who doesn't? The role in modern treatment, complications, subrehabilitation, pearls, and then an overall review. So uni. When you think of uni, what does that bring up in your mind? Is it magical beasts? Is it fantastic machines? Is it unusual people? Does that translate into a fantastic orthopedic implant? We shall see. In my talk on the review sheets, it says your job today is to recognize a partial knee replacement. There it is. So check that box for me. What is it? It's a replacement of just one compartment in the knee. There's a lot of compartments in it. There's 3 to be exact, and there's a little bit different treatment for each of them. So we're going to talk about why this exists. There's a medial uni arthroplasty, a lateral uni arthroplasty, and then a patellofemoral replacement. And they're a little bit different in how they're installed and used. So when we think of a knee, we think of a knee, and that's how we generally treat it. It's all in one. The treatment of one knee is basically all grouped together regardless of compartment. But as we know, if we strip away all the things that our sports fellowship trained partner cares about, we end up with just raw bone. And you can see from a front view, there's really 3 different compartments of the knee. The patellofemoral joint does not articulate with the medial or lateral compartment of the knee. We strip the patella away, we can see there's sort of a unique area of cartilage that the patella rides on or articulates with. The medial and lateral compartment are also isolated. This is one of the reasons the sports specialist can take pieces of cartilage from parts of the knee that never touch another part of the joint and can transfer those. So we can treat these individually. So we have X-rays here. You take an X-ray on the your left side, and you'll see that's a normal knee X-ray. You have good joint space between the tibia and the femur. You don't have many osteophytes, no sclerosis. But if you take that X-ray in the middle, you see that the medial compartment is just quite a bit narrow. There's small osteophytes there. It's not terrible osteoarthritis. You haven't lost a lot of bone. You don't have a terrible deformity, but you obviously have a wearing of the cartilage surface. The lateral compartment looks pretty good. That's one you might want to treat in a different way from a total knee arthroplasty. The far right X-ray here, you have bone-on-bone arthritis in the patellofemoral joint. It's pretty typical for most people's patellas to start tracting a little laterally when you have severe osteoarthritis. I don't really consider that maltracking unless they have subluxation type of symptoms. So this is one way you might treat that middle X-ray. You replace just the medial part of the joint. This happens to be a mobile bearing design. That's why you see that little line there in between the 2 components on your left X-ray. That's the plastic. They always embed things in anything radiolucent in the operating room so that we can see it on an X-ray if we need to, and we can see where it is. That's one of the complications that we'll get to later. On the side view here, you can see it doesn't grab onto a whole lot of bone. It's still a cemented implant. I'm not aware of any porous coated partial knee replacements that really work well. But this design is long-standing, been around for 40 years. Far right X-ray from the previous slide. This is a patellofemoral replacement picture, post-operatively, still has the staples in. You can see you don't see a component on the patella. That's the same as the total knee. We use that patella button that's made out of highly crossing plastic that works well. The potato chip-like piece of steel we stick on the front of the femur is the only thing the patella articulates with. So this is a pretty easy procedure to do. Here's a little example of picture during surgery on what's called bicompartmental arthroplasty. This is getting into the weeds a little bit. If we can replace one, maybe we can just replace 2. Those researchers will never give up. If we look here on the left side, we have a medial compartment uni arthroplasty and a patellofemoral replacement. We leave the lateral compartment alone. The research is a little bit out on this. There's lots of studies out there suggesting that partial knee replacements do a lot better than total knee replacements in the early postoperative period. And a bicondylar total knee is no different from that. But you're installing 2 different things, and so there's some caveats to this. One company came up with this picture of the operative picture here and the illustration on the right, affectionately known as the deuce. Unfortunately, its longevity and its complication rate really lived up to its name. Okay, so we don't put that one in anymore. The materials here, anytime you have a femoral articulation, you're going to make it out of cobalt chromium steel. That's truck axle material. That's the stuff that has great wear properties. You can polish it almost perfectly. The only thing better than that's a ceramic, but they're pretty hard to shape. So that goes for the patellofemoral joint. That's a cobalt chromium potato chip. For the mobile bearings, you have two different articulating surfaces on both the tibia and the femur, so those are both steel. For the most part, if you're clicking plastic into a piece that locks there, that's going to be a titanium piece. So tibial articulation is usually titanium, and patella is always a modern plastic. So again, there's an example of a lateral unicompartmental arthroplasty on the left side, and a close-up of the patellofemoral replacement. A lot of companies make these things. They're pretty ubiquitous across all companies these days, and they all work about the same. So the approaches, there's a lot of different approaches to the knee, just like everything else these days. And most people will use what's called a subvastus approach with a patellofemoral replacement. Why cut into the quad tendon when we can avoid it? Most people that are getting a patellofemoral replacement are usually healthier, more active people, although that's not always the case. It traditionally actually wasn't. But here's the far right picture. You see the incision in blue goes around the patella and around the underside, medial side of the quadriceps muscle. We lift that over laterally, you can see everything in the joint. This middle picture is called a mid-vastus approach, where you split into the muscle. I don't know a lot of people that use that anymore, but it did work very well. And the traditional medial parapatellar is in red here, still used in our bigger patients, very, very muscular patients, and we have a hard time mobilizing that muscle. For a PFJ, you'd use a subvastus or a mid-parapatellar. For a medial uni, you're not even getting up past the patella, so it doesn't matter which approach you're using, you're not extending it past the kneecap. For a lateral uni, it gets a little tricky. Sometimes you have to just pick a lateral approach. Well, in the future, if they need a total knee arthroplasty, then their incision is going to get kind of crazy. But that works well and is minimally invasive. Some people decide to use a larger midline incision, sweep over and go laterally through the capsule. Picking the right patient, as Dr. Cote alluded to, that's pretty important no matter what we do. So unicompartmental OA patient is the right patient. We don't want tricompartmental osteoarthritis or osteoarthritis in the whole knee. It wouldn't make sense. You give them a total knee replacement. Traditionally, the age should be over 60. They should be low demand, and they should be fairly light. These components are not very big. They don't have a lot of bone to grab onto. So they come loose a little bit more often, and that's one of the failure rates of the unicompartmental arthroplasty that we just can't escape. This is not gospel, though. These are changing. The indications are widening, and we're using these in more and more patients. We find that sometimes heavier patients wear out their patellofemoral joints a lot faster than lighter patients. 7 times their body weight across the patellofemoral joint with the steps upstairs, and so that tends to wear out a little faster. Don't pick the wrong patient, the flip side of that coin. That's just as important. Again, we talked about tricompartmental osteoarthritis. Inflammatory osteoarthritis, we're talking about rheumatoids there, or any other severe gouty flare-ups, things that's going to affect the rest of the knee anyway. You don't want to put a partial knee replacement in somebody that's going to need a total knee soon anyway. Patients significantly overweight, that almost goes for all knee replacements. You really young active patients. Now, uni knee replacements are really being used more and more in this area because it's minimally invasive, that's a buzzword. They generally don't have severe ubiquitous osteoarthritis, so you want to give them something that retains their motion in their knee. That's not a traditional indication, but they might beat it up a little bit more and it might come loose more often. Previous meniscectomy in the contralateral compartment makes perfect sense. If the other compartment's damaged, you want to consider the whole knee with your replacement. ACL deficiencies, this is being loosened up a little bit in our indications. You can't do a mobile bearing design where the plastic that moves between the two components is free floating. You have to have an ACL for that or they'll twist it out, it'll dislocate. A fixed bearing, some say it's okay. A bad valgus deformity, a bad varus deformity, you don't want to be correcting a deformity with a partial knee replacement. That's a total knee replacement's job, a tibial osteotomy, or just an osteotomy of the femur in general. You don't really want to stretch them too far. flexion contractures more than 5 degrees. Some will argue with that. But again, if they have that, they probably have worse arthritis everywhere else. Statistics, honestly, only about 5% of my practice is partial knee replacements. There are a large range of physicians across the country that will say, I do none of these, I don't believe in them, or half my practice is partial knee replacements. I think that's quite aggressive. They must have some very unusual practice in a big city where everyone else goes elsewhere. I don't know how they get to that point. They got a nice little niche there. In my practice, it's 5% about. Half of mine are medial, half are PFJ. I honestly haven't done a lateral compartment union knee arthroplasty since I've been here. I just don't see a lot of them. And the ones I do, they usually have a worse valgus deformity. And it's not something I think I can correct with the union knee arthroplasty, or it's something I think they're going to go on to a total knee sooner than later. So that might be something that I'm philosophically dealing with, like other things. So does lateral have a role at all? I'm not totally sure. Certainly it does. There is a perfect patient out there. But this comes down to, if I don't do enough of these, maybe I should be transferring those patients to a center that does 100 lateral compartment unis a year. I don't know where that would be. That might not exist. So union knee arthroplasty has more complications than total knee arthroplasty. That's fact. They can't get away from that in the research. Yeah, they might do better early on. They might feel like they have a more normal knee. But in the long run, they didn't replace the other two compartments, and osteoarthritis is going to get you anyway. Eventually, some people, most people. So bicompartmental union knee arthroplasty, that's two components. It actually costs quite a bit more than a total knee arthroplasty. Cost isn't everything, but it is our responsibility in this world of trying to contain healthcare dollars. So maybe that's a vendor issue, maybe that's a technique issue, but that's something to be paying attention to. And total knee has a longer survivorship. That's not just because it's been around longer, but simply because the rest of the knee usually wears out. That's not really the fault of the union knee arthroplasty. That's because the rest of your knee wore out. You know, that happens. And some people genetically may never wear out the rest of their knee. Fine, but you don't know who those people are. Initial functional results better for union knee arthroplasty than total knee arthroplasty. This is probably the single reason we do this, because boy, we can get them back to whatever they want to do faster and more normally than with a total knee arthroplasty. It's just a bigger surgery, more downtime, stiffer knee, harder recovery. But as you'll see in a little bit, not by much. So why I do it? Yeah, faster recovery. That's really the big one. Less pain. You make a smaller incision, you do less bony work, you're going to have a little less pain. Less morbidity. It goes along with pain, smaller incision, perhaps less risk of infection. I think we can probably tease that out of the data. And you retain normal kinematics. Okay, so we got to talk about philosophy here now. If your knee retains its ACL, retains its PCL, even has a lateral meniscus that's nice and pristine and still intact, your knee is going to move more like the knee you had before I did the surgery. So I didn't change your kinematics very much. I believe some of the reason everyone goes around and says knee replacement does worse than hip replacement. That's a common theme. That's just because there's more physical therapy. There's a little stiffer, knees to work through. The hips generally don't need as much stretching and range of motion exercises. But that's because the kinematics functionally are different in a knee after a knee replacement than before, where everyone can machine a perfect ball and socket. That's easy to do. The knee is not a hinge. So it's hard to get the patient back to the way their knee used to be 20 years ago. So that's a problem. The holy grail of this is the forgotten joint, where they don't really realize that they even have a fake knee in place. That's a rarity, but with union knee replacement, you can do that a lot more successfully than with a total knee. It is difficult to achieve that with a total knee, but it is possible. There are patients that are like that, maybe 5 to 15%. With total hip, it's much easier. So the talk. I don't give a union knee arthroplasty to a patient until I really talk to them about why we're doing this instead of a total knee. They have to understand that this is easier in the short term, but it sets them up for another surgery in the long term. So I philosophically ask them, would you rather have just one surgery and in all likelihood not return to the operating room, or would you risk needing another surgery in the future to get a more normal functioning knee early on? And I kind of play that game with them a little bit to get an idea where their mindset is. And then after I get an answer from them, I do it again. Right before surgery, after I mark the patient, before I walk into the operating room. It sets me up for how aggressive I'm going to be to bail on a uni knee to give them a total, and gives them a sense of expectation after surgery. Complications, patella tracking, that can happen in any knee replacement, really, anytime you're making that capsulotomy, but more commonly in a patellofemoral replacement. If they maltrack before a patellofemoral replacement, that's not the surgery to do. You don't correct it with that. That's just for arthritis. Loosening, that's because the parts are small. Bearing dislocation, only usually for a mobile bearing of a partial knee on the inside. Sometimes that's because you left cement back there. Sometimes they tore their ACL. Failure of the ACL, if you have a mobile bearing and you fail with your ACL, you're going to need another surgery, probably converting it to a total. That's why the total is sometimes so nice. They have no ligaments left to tear. You've given them something that can't go bad for the most part. Progressive osteoarthritis, my rule is 10 years. If I feel they will get 10 years before they convert to a total knee, I think that's a success, even though they had another surgery. If they're converting in 5 or 6 years, it probably wasn't worth it. That's my personal opinion, but that's kind of what I present the patients. And fracture, boy, when we make that medial uni cut, it's a right angle. Nothing in nature is a right angle, and the bone doesn't like it. So when you're malloping that part in, it's sometimes easy to crack that off. Rehabilitation with total knees, discharge same day, right? Right? Yeah, everybody? Yeah, that's the way. Skin heals in 2 weeks, return to work 4 to 6 weeks, range of motion needs to be there by 6 weeks in my practice or I'm manipulating them. Uni knee arthroplasty, discharge same day. Skin heals in 2 weeks, can't change that. Return to work in 3 to 6 weeks, that's kind of a guess. I've had people go back in 10 days or 2 weeks, but that's aggressive. If their skin's not healed, I don't really want them, pulling calves or something. So 3 to 6 weeks, I'll give them an extra week. You can push these people harder, and that's the important part. Range of motion by 2 to 4 weeks. Boy, if they don't have range of motion with a uni knee and I haven't touched their ACL, I haven't touched their PCL, I'm starting to worry about it, like maybe something's malpositioned, maybe something's wrong. So review. Uni knee arthroplasty has a limited role in well-selected patients. That's going to be my stance on it. Multiple partial knee replacements are possible, probably not well supported. I have a lot of people arguing with me on the podiums at the academy, but it can be done. Maybe in some certain patients it should be done, but you'd have to dig for them. Unique complications of loosening, fracture, and bearing dislocation. Boy, if you're ranging somebody's knees, getting that strength and range of motion back, and there's some lump that they didn't have before or something squeaks, that's an X-ray time. Survival and revision rates are better with total knees. That's just plain and simple true. You can't get around it. Rehabilitation can be accelerated compared to a total knee. You can really push them. They won't heal their skin faster, but they'll generally feel a lot better faster. So that's about the end. I got a lot of my stuff from the research. It's not all from Google, but it has to be.